Yes, sir. We are.
Should we start?
Yes, Abhishek, please go ahead.
Yeah, hi. Good evening, everyone. And we welcome you all, the delegates, the speakers, the faculty is all here in the very interesting ACP India case files. And this case file, which was actually started by Dr. Amit Gupta, has gone a long way. And we are very privileged and honored to have joined this elite group of the physicians. And today we have two very eminent speakers along with a very eminent moderator. But before that, I would like to invite our governor, Dr. Anuj Maheshwari sir, who actually needs no introduction, but actually I want actually please to guide us through this case files. And please, sir, I would
Dr.
like to
Abhishek,
welcome.
Thank you. Thank you.
just a minute before Dr. Anuj sir delivers his address.
Yeah.
ACP India case file is actually something which has been developed under the able leadership of Dr. Anuj
Dr.
Maheshwari,
Anubhav, yeah,
his
sir,
guidance.
sure, sir, sure.
And only because of his guidance today, we are here and we were able to receive John Tucker Evergreen Award. So I just wanted to inform the viewers that this program has been awarded with the John Tucker Evergreen Award. So now,
That's great.
Dr. Anuj sir, please proceed with your address.
Thank you, Amit. But whatever we do in ACP, it is not any one person's credit. It is always our joint efforts, and we are always a team. And this idea of the ACP case file has also been jointly conceptualized by myself, Amit, and some ideas have come from Amit. Some of them have come from me, and jointly we made this a unique kind of the program, which could win the John Tucker Evergreen Award last year. So this is always a teamwork. I always believe in the teamwork. Welcome you all here again. And I think this is the last ECP case file in this year. So we are meeting last time in the 2022 in ECP case file, and probably in any program of the American College of Physicians. But we are also having one live program here in Lucknow on 30th for the early career physicians. And this is a physical program what we are doing in in 30th at Lucknow at Hotel Clark Sawat, where we are inviting all the early career physicians before the end of the year, and we shall be discussing the issues what we have already accomplished and what are really to be achieved in the next year. We shall definitely be making a plan. Would request Amit to join on that day virtually. If you cannot come to Lucknow physically, then we can be able to make it more relevant and more useful for early career physicians. Would also like to have the opinion and feedback of the all early career physicians. They can write to me or Amit on the mail. How did they like this program, or what improvement they would like to have in this program? Today we are having a very important case discussion, that is chest pain. Many a times whenever we talk about the chest pain, it is always related to the cardiac. We hardly think about the non-cardiac chest pain, or sometimes if we are not going to certain very important perspective of the chest pain, that is very much important to understand this time. So very eminent cardiologists are with us. He shall be telling us how can we recognize while this chest pain is occurring, and we may not miss the cardiac chest pain while recognizing the non-cardiac chest pain. And after that, we shall be having a very eminent overseas doctor who has been from India, Dr. Shraddha Gupta. Now, she is settled at Arizona, and she will be speaking from the Arizona, and she will be talking about the ACP's various aspects like how can we, a member of the ACP can be benefited, and how can the advancement could be useful for a people, and how Indians can be more benefited being a member of the ACP. So before that, we are having this clinical case presentation, that is the chest pain, and over to Amit to take us forward for this case presentation. Although three Amits are there, I don't know which Amit we shall be taking us to forward, but definitely I know that one Amit is the cardiologist. He shall be telling us about that particular case. Over.
Thank you, Anu sir. And today the session will be moderated by Dr. Amit Kumar Dey. And I will request Mayank to display the CV slide of Dr. Amit. Dr. Amit is a very dynamic physician based in Kolkata, and he is the member of the Early Career Physician Council of ACP India Chapter. And he is also very popular among the early career physicians as well as the diabetologists in the country. So, Amit, now it is over to you, and you can take the program forward, please.
A warm good evening to everybody, although it must be cold in some parts of the country as well as in other parts of the world. And it makes it all the more special since this is the last case files of this year's season. So it's important that we make it very interactive. And as our governor sir has already introduced that over the last 1 year and so more, ACP case files has done wonderful in terms of its reach out, especially to the early career physicians with some mind-tickling case presentations and then some thoughtful, discussions on physicians and their outlook. And today we also have some kind of a similar discussion. Thank you, Dr. Amit Gupta, for my kind introduction. And without much delay, let me introduce our topics today. So as sir has already said that we are going to have two very interesting presentations. So one is an approach to a case of a chest pain. And, right from the younger days, from our undergrad days, in our internship days, to our early postgrad days, we have always been, we have always found a challenge in an approach to a patient with chest pain. So whenever a patient walks in with a chest pain, it's always been you start doing the differentials. So we have Dr. Amit Kinare with us today. He's an eminent cardiologist. Mayank, can I have his CV on display? So Dr. Amit Kinare is a DM cardiology from Jabalpur. He's also an associate professor, and he's done his DM from the Lokmanya Tilak Medical College in Mumbai. He's a member of CSI, ACC, and SCAI. He has over 5 publications in various national and international index journals with more than 10 citations. And he's also a reviewer at national and international journals. So we all look forward to how would he approach a case of chest pain and what are the differentials. And I'm sure we have a lot of learning point and discussion points to come out of that. So over to you, Dr. Amit Kinare, for your session.
Thank you so much, Dr. Dey, for the kind introduction. So I think so I'll be referring to all the Amits out here with their surnames, if they don't mind. And we'll proceed. I'll be sharing my slides. Yeah. I hope I'm audible.
Yes, you are, doctor. And your slides are also visible.
Thank you. Thank you so much. Okay, fine. So a very good evening to all eminent physicians, all senior people out there. My sincere thanks to Dr. Abhishek Srivastav. Sir has been a kind of an elder to me, a very good senior, a gentleman to the core, for introducing me to this particular forum. I was probably unable the same. But yes, thank you so much once again. And without wasting much time, I will straight away cut into the topic. So despite the fact that Dr. Dey basically introduced that I would be talking about chest pain, probably we have a lot many lectures and deliberations on chest pain. So I won't be dealing much into chest pain, but I would be dealing into some few cases, some basic real life cases which talk about issues which probably present as chest pain, or more aptly, as we might refer to them as, which masquerade as chest pain or ACS. So these are 3 real life cases probably that I've seen in a span of just the last month, let me tell you, in my ICU. And they were a serious kind of a discussion that happened in this regard as to how do you diagnose them. But finally, we happened by all methods that we employed, we are able to diagnose these 3 cases. So I'll be describing all 3 of them serially. So a quick analysis basically leads to an easy diagnosis, but at times you tend to have that clinical bias. For example, at our center, which is basically a medical college, I work in a government setup. So this particular medical college obviously tends to have maximum cases of chest pain, which tend to be non-cardiac. And out of those with probable, most likely probable or a possible chance of having a cardiac origin, most of them are being labeled as patients with probably unstable angina or maybe STEMI or maybe NSTEMI for that matter. So apart from that, your thinking tends to be so very tunnel that you are not able to make any other diagnosis. Many times these patients are referred to us and probably we need to go through this tree. So that is what is important. The thorough clinical examination, they will be overemphasized, and follow up with investigations. I think so. Investigations are a very important tool nowadays to alter the final diagnosis. So your tentative diagnosis is always tentative. Let me tell you that. So that is important. So looking at coronary artery disease. So this particular coronary artery disease, to label somebody as having that is very easy. At times, I believe this is overdiagnosed. We need to look at each case individually. So this gentleman was referred to us, 54-year-old gentleman. He had episodes of syncope, approximately around at least 2 to episodes of syncope.
I think network issues are there.
There has been some network issues and probably the streaming. Is it streaming still, Mayank?
He is actually looking, he's actually visible as an online person.
The streaming is online.
Streaming is
Sir have
also-
network issues, so he is left.
Yeah. So no, Dr. Kinari is there, but I think his slides are not visible, perhaps. So if you can just reshare. Dr. Kinari, if you can hear us.
Just, I'll get in touch with him.
Okay, sure. So I think while we are trying to connect back with Dr. Kinari, I think over the I'm sure we are having a lot of student members as listeners and a lot of early career physicians and also some senior members as listeners. So while we are there, if we have sir with us, if Dr. Maheshwari sir is there with us. Yeah, okay. We have Dr. Kinari is back with us. So can you try resharing your slide?
Sure. Please just give me a moment.
Sure. Right. It's good to go.
Right. I'm really sorry for the technical slack. Okay. So a 54-year-old gentleman, syncope, as I just described, 3 episodes associated with shortness of breath, which subsequently increased to class 3 over a period of a week. There was some amount of cough, mostly dry, but there was some productive cough that was seen ever since the NYHA class 3 was noted. Past history, there were similar episodes of syncope in the past, probably that the patient just referred to. Okay, he was a known case of hypertension on Ayurvedic treatment. Okay, he never bothered to visit a physician for the same. That's fine. There's history of facial palsy, probably most likely Bell's palsy, about 7 to 8 years back, from which the patient recovered uneventfully. So an examination, nothing much basically, I would say. Pallor cyanosis were not seen, pulse of around 96 per minute. That was the only thing, tachycardia. Apart from the blood pressure was slightly on the lower side. We couldn't make the patient actually sit, hence the blood pressure was taken in the supine position as well as the standing position. We made the patient stand just to see that there's no postural kind of hypertension, so that we rule out orthostatic hypertension. Respiratory system examinations, just fine Krebs is all that we could see. Apart from that, rest of the system examination was normal. So what was the dilemma basically with respect to diagnosis? The thing is that the patient was referred to as an ACS. He had changes in the ECG, where probably where the referring RMO probably thought that yes, there are subtle changes which probably could make the patient a case of inferior wall MI. So he labeled the patient as inferior wall MI plus posterior wall MI. At the same time, he had RBBB, that is right bundle branch block pattern, with an LAFB, probably most likely due to hypertension. So bifascicular block. But despite the fact that we started him on treatment, oxygen saturation on the lower side is basically a very red flag sign, which seriously needs to be taken a look at. So how did we progress? So after labeling the patient as an ACS, probably the most important thing that we need to do is we need to restart the process of thinking, and that is exactly what we did. So we had some investigations at hand already, which probably made our life a bit easier. We had CT brain, which was basically labeled as normal. Hence, the likely etiology of having a syncope is something else, not related to the neurology. Apart from that, CBC showed that there was WBC, rise in WBC with some sort of neutrophilic predominance. Outside the ECG is something that I just described, and rest of the routine investigations were within normal limits. So what we did was we did a drop-eye. Drop-eye is slightly on the higher side. In our setup, a drop-eye of 0.04 is what is considered to be normal. Anything apart from that is elevated. Anything more than 1 is high. Anything more than 10 is very high. So renal parameters were within normal limits. CPK-MB for that matter was normal. HbA1c was fine. Viral markers were negative. So what next basically? Okay, so we went for imaging straight away. So imaging is something that revealed or uncovered what the disease was. So chest X-ray, as I'll just show you, right focal upper lobe oligemia. Okay, right lower zone was basically dotted with non-homogeneous opacities. Serial ECG, nothing much, I would say northwest axis. That is probably because of LFB and RBBB. Okay, there was T inversion as well as you had S1R S3 pattern. Okay, this pattern can be seen with RBBB, it can be seen with other disorders as well. Okay, so this is something non-specific. 2D echo showed right ventricular free wall hypokinesia. So this is something that we looked at. There was significant hypokinesia that was noted. So initially we thought that there was septal kind of a motion aberrancy from the interventricular septum, but finally we noticed that in the fourth chamber there was right ventricular free wall hypokinesia, obviously with right ventricular volume overload and right ventricular pressure overload. Dilated RERV, severe PH and severe TR. This is the first thing that gave us an idea as something is wrong with the right ventricle, probably to do with the pulmonary circulation. A D dimer was ordered, and as probably expected or not expected, the value was on the higher side, 6.7 micrograms per ml. A normal value in most labs is less than 0.5 microgram per ml. Okay, so this is definitely elevated, more than 12 times, I would say. So this is what the ECG was basically. You can see the date out here, it is 29th of November. This was when the patient was from outside. You can see an RBBB pattern with secondary STT changes, this T inversions. Apart from that, you can see here as well, you can see a small R wave in both lead 2 and lead 3, which is suggestive of an LAFB pattern. Obviously, there was hypertension. You can see that AVR is positive out here. So this is more of a northwest axis and RBBB with, you can see small T R waves out here, which is LAFB. So having an RBBB with this thing with a LAFB is basically bifascicular block. These T inversions is something which cause some amount of a diagnostic kind of a problem for the junior residents. They were looking at this. This was his ECG a few days later that we had the same kind of pattern, but slightly improved, I would say. Okay, nonetheless, AVR is still positive, still this T inversion still continue to be there. They're gone deeper now. Okay, this is the X-ray that I was talking about. You can see out here, there's focal oligemia on this particular side. On the right side, you can see there's some amount of oligemia, though not very much appreciable, but yes, there's definitely something that you can see. And there were non-homogeneous opacities down there. CT pulmonary angiography is the one that was the clincher. It gave us the diagnosis. We did a 3D reconstruction. We are fortunate to have this at our center. And these were the various images. Probably I'm not very good at reading them. But finally, what the diagnosis turned out is there was partial filling defect in bilateral upper lobe pulmonary arteries, which was suggestive of pulmonary embolic disease. So this was the patient was treated in medicine and then was referred to us because the saturation as well as the patient's condition was not improving. So this is one of the case that we see. So final diagnosis was a case of massive pulmonary embolism because we saw hypotension. The patient presented with a blood pressure of 84. That is what we noted, and it was basically a case that was misdiagnosed as ACS, most likely ACS. So case 2, going through the history very fast. 52-year-old gentleman, chest pain of a day, associated with shortness of the same intensity and interval as the previous case. He had a history of a similar episode about 1 year back. Details are not available. Known case of hypertension for the past 10 years on treatment. So what next? So this patient was obviously once again referred as most likely a case of ACS interval, and my ECG changes were quite suggestive. Probably when I had a look at the ECG, and I also thought of the same, but there was some amount of a difference. Basically, it was not a kind of a typical interval MI ECG that you would note. So after initial investigation, the patient was taken for a coronary angiography with obviously the back of the mind that yes, most likely the patient could require a PCI in the same sitting. So this is the ECG of the patient. You can see there are QRS complexes out here, which is there is normal axis though, but most of the axis is towards the left side. You have a few P waves out here which are not being conducted. Apart from that, you can see there is T inversion that is noted in lead 2 and most of the other chest leads as well, starting from V3 to V6. This is the elevation probably that we noted, probably created confusion as to whether this could be a septal MI, which could then further subsequently progress. So that is the reason we went for an angiography, and to our surprise, let me tell you, the angiography came out to be normal. This is the picture done by one of our colleagues. Angiography was noted as normal. So once again, reinitiate the process of thinking what it could be like, most likely. So thorough investigation once again was done. All evaluations were completed. And one thing that was very commonly noted was basically a pistol shot femoral pulse. One of our second year residents probably had time. He also had the courage to go and have a look at his femorals, and he probably noted a pistol shot femoral. He brought it to our notice. Then we had blood pressures as well. Blood pressure in one of the arms was 130. In the other arm, it was approximately around the same. The lower limb, basically, right lower limb, it was 166/86. So the Hill's sign is positive. This is very typical of aortic regurgitation. And almost the same thing was noted on thorough further cardiac investigation and examination. Okay, so auscultation is really important, I would say. And Austin Flint murmur almost clinched the diagnosis. We do have an echo at our hand. So that is the most important thing for us. Okay, we narrowed down to the diagnosis of aortic regurgitation, and to support the same, we had an echo. There were no peripheral signs. Usually it is said that once you have a Hill sign positive, then probably you have peripheral signs associated. You tend to have Water-Hammer pulse, Corrigan's pulse, so on and so forth. You tend to have, but there was no wide pulse pressure. So we don't have typical textbook pictures in our patients. Many times that is one thing to be noted. Okay, and obviously all of us have experienced the same. 2D echo obviously labeled the patient. It was bicuspid aortic valve, mild to moderate aortic stenosis with severe aortic regurgitation. So this was bicuspid aortopathy. Okay, LV ejection fraction was 20-25%. Unfortunate. The patient had severe LV dysfunction. So in this case, the best thing to do is refer to a CTVS surgeon, let them make an opinion. But this is what it was. It was a case of severe AR and AS that was probably there for a period of approximately a year or so, which was wandering around, which was probably misdiagnosed as a case of chest pain. Coming to case 3 quickly, this is the last case. History, I'll just go to. 32-year-old young male, sudden onset of weakness and numbness in lower limbs. He probably thought that it was due to lifting heavy weights. Okay, then there was subsequently painful swelling of both the lower limbs, which probably progressed distally. It started proximally, that is the way he told us. NYHA class of 2, not associated with any kind of PND or orthopnea. Chest pain, no Senker, no significant past contributory history. So what kind of diagnosis do we? So most likely the first thing is making a diagnosis of DVT, most likely pulmonary embolism. Patient was initiated on heparin from outside. As a good move, I would say. So what was the dilemma basically? Okay, dilemma was something different. The patient subsequently deteriorated. Creatinine on admission was around 1.78. An acute rise was seen on day 3, 7.82, subsequently 10.59. But no decrease in urine output. Unfortunately, this patient had to undergo a dialysis. He's still admitted with us. He was put on ventilator as well. So how did we progress? So once again, look at the diagnosis, look at the patient, reinitiate the cycle of thought. The thought process should go on. Okay, so there was pitting edema, non-pitting edema that was seen with some signs of local inflammation basically. Okay, the patient was having tenderness in lower limbs. There was a bit of redness as well. In one of the limb, though it is not typically seen, let me come to that. Pulse of 80. The lower limb pulses were not that well palpable. The right popliteal, posterior tibial, etc. were not palpable. Left popliteal, the pulse was feeble. BP was fine. Lower limb BP was reduced comparatively. You expect that the lower limb BP should be higher than the upper limb BP. Apart from that, systemic examination was fine. So what we did, investigations, obviously, we find that yes, TLC is elevated with neutrophilic predominance, could be reactive. Liver parameters obviously elevated. Transaminases were elevated. Renal parameters, as I just described, continuous elevation of the creatinine. So there was something to do with the renal system as well. D-dimer was 2.2, once again elevated. Less than 0.5 is normal in our scenario. PT was fine, I would say. INR was slightly elevated. Probably could be due to heparin or maybe some other medications that the patient was. Sinus tachycardia is the only thing that we noted on ECG, and there was left atrial enlargement. There was a bifid T wave, and there was a negative P terminal force noted in lead V1. Rudico once again is the helper, is the one that helps us to cleanse the diagnosis. RSD with severe mitral stenosis. There was moderate to severe tricuspid regurgitation, most likely of organic origin. Severe pH was noted. LA, the size was on the higher side, 4.8. And there was a clot that was noted, 1.8 by 1.2 by 1.8 millimeters, and LA appendage clot. So LA appendage clot is in mitral stenosis is a very common occurrence. It is in fact the most common site for having a clot. Apart from that, thankfully, LV system was LV systolic function was fine. What did the color Doppler relieve? As expected, once you have a clot, always think of systemic embolism. Bilateral lower limb color Doppler suggestive of right SFA thrombus. So that is one thing that we noted. Apart from that, renal artery Doppler also suggestive of left the renal artery clot, which is a thing which is very unlikely. Probably the patient had a thrombus that had migrated, or maybe there was some other disease as well, which we are currently investigating. So this was to label the diagnosis. This is still a tentative diagnosis. We have not come to the final diagnosis. A case of left atrial clot with systemic embolization, and probably which was misdiagnosed as a case of DVT, likely DVT. Thank you so much for your patient listening. Thank you.
Thank you very much, Dr. Kinare. I think all three of your cases were pretty interesting, and most importantly, they were like an eye-opener cases. So let's look at you can just take us through each one of them, once with us. And one thing which I would like to understand is that the first case was a case of pulmonary embolism, and I think most of us who've been working in the field of medicine, or even cardiology or interventional cardiology, as you are doing, we would have encountered a lot of PE cases during the COVID days. So, I just want to understand from you that how would you approach a case with PE, especially keeping in mind, like your case, a patient which came in a state of cardiogenic shock. So let's just give us an overview of the treatment, of how would you approach, and what are the treatment modalities in cases of PE. Dr. Kinare.
Right. Thank you so much. So coming to the diagnosis is very essential. The key thing is making a diagnosis. And for that, probably you need to keep your eyes open. Pulmonary embolism, if you look at literature, what it says is that it is the third most common cause of chest pain. So when patients come to you with chest pain, you should have a modality for diagnosis. We took some time. There was approximately a time lag of around 7 days from admission to the hospital to making a diagnosis. But the patient was put on heparin. That is obviously the therapy of choice in these patients with pulmonary embolism, because that is all that you can do. Unless you have a massive clot that is sitting there, probably you can do a lysis, or probably you can call your CTVS friends, your cardiac surgeon friends, to operate and take out that mass, that particular clot that is sitting there. So in this particular scenario, the first thing is that making a diagnosis. What textbooks typically tell us is that in case you have a patient who comes with chest pain and probably is not fitting into that typical case of MI, you're not able to have changes. You have such borderline elevations in troponin, things are not fitting into that particular subset. The best thing is to go for a CT. CT is the first thing that you do. And the CT that they actually recommend is a triple rule out protocol. Triple rule out protocol. That is three things, obviously, as the name suggests. First is obviously you do a CT coronary angiography. The second thing is you do a CT aortogram to rule out dissection. Dissection is a very common thing that probably we do not. And since the patient was hypertensive as well, that is one of the things that you should look for. And third thing, obviously, is pulmonary embolism. So these are three things you definitely should rule out in cases which are not very typical in terms of an MI. Obviously, with experience, things will tell you in which direction you should go. But that is the first thing. Second thing is then, as investigations such as do a D-dimer, do an ABG for the patient. ABG was fine, I would say. And there was some amount of desaturation when the patient was ambulatory. So keeping all these things in mind, looking at the picture, there was no saddle embolus. So we decided we'll simply continue with heparin. So we calculate the Wells score as well, just to classify the patient, whether his Wells score is something that is available. It is freely available all throughout. You go through the net and you'll find it. So you calculate as to where the patient stands. You can classify him as mild, submassive, and massive. He was massive on clinical examination, but he improved. We offered him. We continued that, and we counseled the patient for an oxygen concentrator. So the only thing, the population, you can offer him an IV anticoagulation. We put him finally on 5 mg BID. This was non-provoked. Whenever you have embolism, you can have something that is provoked or something that is non-provoked. Provoked in the sense you have some other disease.
Dr. Kinare, your voice is breaking up. So
probably her liver disease. Or
yeah, your voice is breaking up. We couldn't catch the last bit, but if you can try this with your video off, maybe you get.
I'll just put off the video.
Yeah, I think you'll get a better video.
Right. So what we did is we finally discharged the patient by on a DOAC, that is Apixaban, that doesn't require any kind of monitoring, no PT-INR monitoring, so that he can do with the hassle of monitoring that particular PT-INR. So we offered this particular therapy to the patient. At the time of discharge, the patient was showing some signs of desaturation as he was ambulatory. He was having his lowest recorded saturation was around 90%. 90% when he was ambulatory after exercise. So the best thing is you can make these patients exercise. You can do a 6-minute walk test if the patient is able to tolerate the same. And the thing is you offer long-term, and chest physiotherapy is the best that can be done. So all symptomatic measures. You don't have anything specific as to how you can get rid of those particular clots, because once the clots are organized there, you cannot lyse them. Even if you offer fibrinolytic therapy or whatever for that matter, it is difficult for these patients to be lysed. That is how it is. So the patient is doing fine. I had a word with the patient yesterday morning and he's doing fine right now. He's improving. I believe he'll continue to do so. But then close follow-up is also essential in terms that these patients might land up with pulmonary hypertension. Okay. They may not completely come out of it. Some patients do well for that matter. So close follow-up is very essential. Yes, sir.
Yeah, I mean, thank you for that input. And just to add, I think, a bedside echo is of real help because, in clinical practice, we often, we do get cases of PE, and usually it comes in with a high-end suspicion when you're really suspecting the patient to be something else, because you don't get those typical ECG changes that we read in the textbook. So
right.
So you might say it would be a very handy tool, because whenever you're getting an RV dysfunction, you would have a higher end of suspicion towards the PE.
Absolutely.
Yeah, just one more thing I would like to understand from you is that, when you really think about an embolectomy or, going for a, for some kind of a aggressive measure, especially if the patient is having hemodynamic instability, is it when especially a major branch cutoff is there, or like how do you clinically decide about that in some cases?
Right. So just as I referred to previously, you have a well-scoring system that is available, wherein you can classify the patient as probably a case of mild, submassive, and massive. So in case patient, many times the patient might have one particular parameter wherein he fits into the massive group, another parameter wherein he fits into the milder group as well, or maybe one wherein he fits into the submassive group. But we take the most common symptom that is available for us. We go clinically. For this patient, there was hypotension that was noted. Probably he had a BP that was lower to start with. So since he had a blood pressure of somewhere around in the 80s, 84 was his systolic blood pressure, we decided to treat this patient as a case of submassive pulmonary thromboembolism. Though there was nothing to lyse from our side. In case if you're planning for an embolectomy, as you referred to, embolectomy, in case you have substantial mass, probably the most common thing in case you have massive pulmonary embolism, you might at times see a saddle embolus, a saddle thrombus that is seated at the bifurcation of the pulmonary artery. That is the time probably you can go for a surgery, because the best outcomes and best results are offered when you go for surgical intervention in these patients, because you need to take out that particular, in case the thrombus, basically if it is seated there and it tends to dissociate and reaches the lower circulation, the lower pulmonary circulation, it becomes very difficult. There's nothing that you can retrieve. So embolectomy is in those cases wherein you find that there is a significantly big thrombus that is sitting there and can be taken out or can be removed or retrieved by the cardiac surgery team. Only in those cases you tend to refer Otherwise, in most cases, the first thing is make an early diagnosis. Earlier, the better, because because if the patient is not offered that kind of treatment, probably there'll be multiple such thrombi, because thrombus tends to beget a thrombus. There is this particular cycle tends to happen. And obviously, you tend to investigate as to what is the cause of that thrombus. Does he have any inciting factors? We obviously did a fibrinogen assay. We did other tests as well, but nothing came out to be positive. I did not include that in the slide, but nothing came out to be positive. There is a big chunk of investigation that you need to do. But with treatment, the patient improved, so we decided we'll continue the same. Yes, sir.
Wonderful. And you know, in a follow-up care, how long do you continue with the NOACs, and what are the guidelines tells us into like, you know, for how long?
Right. So in case, true. So if you're putting these patients on DOACs, which is the most common therapy that is being advocated as of now currently, these patients, the best thing that you need to do is you need to find out whether these cases are provoked or unprovoked. If this cases, if the patient is a case wherein this particular embolus was provoked, that is, he had probably a malignancy, bronchogenic carcinoma, or probably he had gastric malignancy whatsoever, or probably he had some other issues of probably he was moribund, he was bedridden, or probably he had a DVT or something, whatever, he had a fracture femur, for that matter. So in these situations, it is a case of a provoked kind of a pulmonary thromboembolism, where treatment they advocated for a period of around 6 months. But in case it is unprovoked, it is best that you continue, for example, as in this case, in the case that I just demonstrated, it is always advocated that you continue this management for lifelong, because you do not know when the patient will suffer another kind of an embolus, probably not within the venous system, maybe even the arterial system for that matter, and he might land up with a stroke. So it is always advocated that you classify these patients, look for a cause, and as far as possible, I always try to keep the patients on lifelong therapy. That is how it is. Yeah.
Absolutely. Thank you. I think these are very important inputs coming from you. And the rest of two of your cases, I think I would say echocardiography was the key factor in making the diagnosis. And of course, very beautiful cases you had displayed wherein there can always be a diagnostic dilemma. Thank you very much, Dr. Kinare. And I think we can take in some more questions at the end of the
Sure.
of both our speakers' talk. So I would like to move on to our next speaker. So we had some nice dissections about cardiology right away, understanding. And now we want to move into about the skills of a physician. And we have with us from our overseas chapter, Dr. Shraddha Gupta. And Dr. Shraddha Gupta is currently working at Chandler Regional Medical Center in the Department of Internal Medicine. And she is also a co-chair of and worked as an assistant clinical professor at Creighton University Department of Medicine, Division of Internal Medicine. She has received a certification of the American Board of Internal Medicine. She has Arizona State Medical License. She's a member of the American College of Gastroenterology Society, American College of Physicians, Worcester District Medical Society, and Indian Medical Association, and Maharashtra Medical Society. And she has been also awarded the Wellness Award in the Arizona chapter. So a warm welcome to you, Dr. Shraddha Gupta, and she will be taking us on her talk on a mindful physician. So that's what she's going to discuss with us today. Over to you, Dr. Shraddha.
Hi, thank you. Is the audio good?
Yes, you're audible, Doctor.
Okay. How do I share my slides?
There's a share screen option, a green color button right in the bottom. Mayank, you can help?
Oh, yeah. Got
Yeah.
it. Yeah.
Yes, your slides are there, Doctor.
Yeah. So Dr. Day already talked about a little bit about me. I'm an internal medicine physician practicing in the inpatient setting in the hospital, which is Chandler Regional Medical Center. Also an assistant clinical professor at Creighton University. I'm certified as a life coach and a mindfulness teacher, and I'm a wellness champion with the ACP. Thank you for having me at ACP India. I have no disclosures. Whenever I start to give a talk, I generally like to say a little bit about myself. So growing up in India and getting through All India PMT and then medical school, life was always about studies and focus on what you want to do in life. as a personal passion, I always was very interested in just mind, psychology, and how things work and how what we think improves or just affect our life around. Growing up, finished my medical education, moved to the United States of America for residency and fellowship. As a third-year medical resident, I was pregnant with our first child, and being responsible for another human being kind of gave me a different awareness of how important wellness is. Um, uh, I became a mother for the first time, and I was responsible for this young child's life with me. And I thought that I need to be happy and satisfied with it myself to be able to provide for my family and my patients. Um, I did my residency at the University of Massachusetts. There was this physician named Dr. John Kibitson, and he is a mindfulness teacher. He started this program called Mindfulness-Based Stress Reduction Program. It's an 8-week course. I did this course personally at the University of Massachusetts, which talks about mindfulness and applications of mindfulness. He has applied mindfulness on patients with chronic pain, prison inmates, medical students, residents, physicians, everywhere. So I felt the benefits of mindfulness kind of just sprinkling in my personal and professional life. And I was taking on a role of a chief resident, which is like a junior faculty in my residency program, and overlooking the guidance of 75 residents. So as a chief resident, took a lot of these educational points from my own life and kind of implement them on the other residents, and saw a great improvement in their wellness as well. This was really well received by the residents and the faculty as well. Along this line, I came across something called as a life coach. So the way I like to explain what a life coach is, when we talk about a therapist, I've never talked to a therapist personally, but my understanding of talking to a therapist or a psychologist is they're always focused on the past life, what you did in the past and how that affects our day-to-day life and future from now on. When we're talking about a mentor, we're always looking at future, what we want to achieve in life. But a life coach looks at the present, right now, what I have and how I can change that. So a life coach sometimes, will give you a helping hand where you are swimming deep in the pool and you need somebody to hold your hand, where you have these thoughts which you're not aware of, but these thoughts are the things that kind of change your life right now and reflect on your life. And then they sometimes applaud you when you've had a winning streak and be like, yeah, good job, well done. So, when I started this journey, I had these thoughts. I'm not good enough. I wish I was perfect life, or nobody cares. I'm alone in this. Everybody's judging. I have no control and I'm a failure. And this baggage felt on my shoulder, which was really, really heavy. Doing all this work in my personal life, I was able to successfully become an independent and a happy physician. So my question at that point to myself was, if this works for me, will this work for more people? Like if n equals to 1 for myself and it's working, can I imply the same knowledge to more people and see if this works or not? And I could find a lot of studies that showed that mindfulness or coaching was helping out in residency programs, in other prospective studies that I could see, primary care physicians, faculty positions. So I was like, yeah, this works. This works. So as physicians, we always like to see what is the real definition of something. So International Coaching Federation defines coaching as partnering with clients in a thought-provoking and creative process that inspires them to maximize their personal and professional potential. So it is collaboration between the coach and the mentee in a way that it brings out the best in your personal and professional, or whichever area you want to work in your life. So I could see the benefits of this working in my life, and I really wanted to take advantage of this this new knowledge that I had gained and continue to work as a physician. This is exactly the time when COVID has hit as a pandemic, and I wanted to get some more mindfulness skills and some coaching skills. So I enrolled myself in a coaching school, And the reason why I enrolled myself was because this model was really intuitive. As a physician, we always are looking for something that we can follow in a stepwise, like, history taking, diagnosis, test, and then reaching to a diagnosis and then treatment. So this coaching model felt like that. There are 5 components of this model. The C is a circumstance. The way I like to describe circumstances is just something completely neutral. That means I am a woman physician, and I can go to court and prove that I'm a woman and I'm a physician with my MBBS degree. I live in the United States of America currently. I have a home address. I have bills that I can prove. So circumstance is completely neutral in this situation. Whenever we think of a circumstance, like if I say I'm a woman physician, if somebody who is not in my shape or in not my shoes will think, oh, wow, she might be busy. Oh, we don't know if she can balance family versus personal life versus work life. Whereas for me, it comes as, okay, I have worked hard and achieved where I am and what I am today. So the moment we talk about a circumstance, there comes a thought in everybody's mind. So we can say, this is winter. The moment I say winter, for somebody who's experienced snowstorms will think about snowstorm and, oh my God, I don't want this. But somebody from the desert would be like, okay, it's a good weather for some time. So there's always a thought that comes with the circumstance. In about a day, we get about 40,000 thoughts. And the results that we see around ourselves is because of the thoughts that we have. The thought generally creates a feeling. The feeling is the sensation that we feel in our mind or body, like happy, sad, angry, overwhelmed, depressed. And this is what we work for. If I ask a room full of 100 people, what do you want to do in life? Most of the people would tell me they want to be happy in life. So happy is a feeling. That is what we are working towards. Anything. Say some of us are working hard in our professional careers because we want to achieve a certain kind of professional success, monetary success, and we want to be happy, proud of ourselves and achievements. So that is what we are trying to achieve. The action or inaction is self-explanatory, but it is what would make us achieve the results. So if I'm feeling motivated, I would do more of the same thing. So say I want to lose 100 pounds and I'm feeling motivated to lose 100 pounds, then I will go to the gym, I'll work out, I would eat healthy, I would make a diet plan. If I'm not doing that, then that's the inaction part. So that means if I'm not working out, if I'm not making a meal plan, if I'm not sticking to a diet regime, then I would not be able to get my results. And the R is the result. So CTFAR is the acronym that we talk about in this coaching model. So I didn't like to explain my physician friends with this model because it is something that most of us have gone through. So if we take as a circumstance C, all of us were pre-med students. We were in maybe early school or 10th or 12th and thinking that we want to be physicians. So that's a completely neutral situation, circumstance. We had a thought, I want to become a physician. We had a feeling. The feeling was motivated. I felt motivated to become a physician. The action we did, we studied hard, we prepared for our entrance exam, whether it was All India PMT or CET or new names which have come up. We did not pass away time on social media or do a lot of other stuff that other colleagues were doing who did not want to be physicians. We were focused in our work. We knew we wanted to achieve going to med school, and we did that. So the result was all of us are accomplished physicians. Now, because we've already recently dealt with a big pandemic and probably dealing with still, this is something that might resonate with all of us personally as well. So the COVID pandemic is a situation, when I say it's a neutral situation, I get a lot of pushback sometimes. But you might be able to see why I'm calling it a neutral situation. And there is something called an unintentional model, which is what our default thought process is. So, like I said, if I'm a female physician, my default is I feel proud of being a physician, or I'm proud that I'm a female physician. But somebody's default could be, oh my God, she's not giving enough time to family, or somebody would be like, oh, she's cutting corners at work. So that's the default. That's called the unintentional model. And then sometimes to achieve results, you could have a shift in your thought process, and that's called the intentional model. All of these slides, I could go on and talk for hours, but we're trying to be concise here, and I really want to spread the message, and we'll be happy to take questions at the end of the presentation. So I wanted to go and show you how you can change or shift your thought process from an unintentional model to an intentional model. So for a moment, let's just put the COVID pandemic as a neutral circumstance, which is a C. So the initial thought when we all started with this pandemic and there was no knowledge about what it is and how we can do and what we can do and what are the options of treatment, we all were tired. We all were drained out, burned out. We didn't know what to do. So our thought was, I cannot do this anymore. Like, I'm done. Like, why did I choose to be a physician? This is not what I signed up for. A pandemic is what not on my horizon. The feeling was overwhelmed. I just felt like, I don't know what's happening. I don't know how to deal with this. The action, when you are overwhelmed and you are thinking, I cannot do this anymore, you are not paying attention. You are not focused. You are not taking care of yourself well. You're not taking care of your patients well. You're not taking care of your family well. You're always very impulsive. You're getting frustrated soon. You're getting angry at people you love. You are not satisfied in life. You're not just a happy person. So the result was burnout. All of us have experienced this during the pandemic. We were all burned out. We didn't know what to do. We didn't know how to get out of the situation. And then this is the unintentional model. This is the default that our brain was trying to show us because it was trying to protect us from the harm that the pandemic could do to us. This is all. The default model is generally the old brain. When we were all cavemen, the brain was trying to protect us by not allowing us going out of the community, doing something heroic, because there were not resources out there to protect us. So this is all just our old brain telling us and protecting ourselves. If we keep the COVID pandemic as a neutral circumstance, which is the C, and have a different thought, just change the thought from I cannot do this anymore to I will do my best today. Just today, for this only patient, I will be 100% focused. I will do everything in my capabilities to deal with it. Like Dr. Kinari just explained that case of PE. For that moment, he was like, I really want to help this patient. He's, we don't know, it's not ACS. What do we do? Rethinking, but giving everything to that very moment. The feeling is hopeful, right? You are hopeful because you trust your instinct, you trust your knowledge, you trust your training, you trust that there are ways and tests you can do in order and find what's going on with the patient. The action, you show up as your best self, like Dr. Kinari did. He was his best self. He came up as the best cardiologist for the patient, advocating for the patient, trying to figure out the tests that he needs to order, diagnosis that he needs to make, medications that he needs to start. So he does show up as his best self. And the result is you develop resilience. You with every patient, if we have this thought process, I will do my best just now. I will do my best today. I will do my best in this very moment. You slowly come to a place where you can change your feeling from being overwhelmed to being hopeful, being happy. Happy is what we're looking for here. So being happy in that moment, So the first one was the unintentional model here. And the second one is the intentional model with just one change of the thought from I cannot do this anymore to I will do my best, changes your results from burnout to resilience. I will go over this patient scenario with you, and things might be a little bit different here versus back home, but I guess the message will still resonate with everybody. So this is a very personal case. I have this 80-year-old female patient with multiple comorbidities, including cancer on chemotherapy, and she was admitted to the hospital. She was treated for COPD exacerbation, was improving. We had a very good patient-physician relationship. She also praised me for my amazing bedside manners and overall personality, and she felt very comfortable for me to take care of her. Next day, I received a call from radiology that she has an incidental finding of a dilated aorta. We discussed the plan and came to the conclusion that she wanted to talk to the thoracic surgeon. And she was in her 80s, like I said, and a very poor surgical candidate because of her cancer and other comorbidities. So I had already discussed that the plan would be to monitor the size in the next 3 to 6 months, and we'll see what happens. And I could feel that she was really scared about her health. She lives alone. She does not have any family nearby. Her husband has passed away. So the next day morning, I received this call from the nurse stating that the patient wants another physician, and she does not want me taking care of her. And that was very one moment I was like, what happened? You know, we had this beautiful relationship where she was comfortable with her care under my care, and suddenly she doesn't want anything. But I've been practicing, you know, coaching and mindfulness for a while now. So I was able to run through the model for myself. And the model, again, here for everybody to notice is the circumstance, thought, feeling, action, inaction, and result, CTFAR. So I went through the unintentional model. So this 80-year-old female patient recovering from COVID, incident finding of dilated aorta, fires me and requests a new physician. My thought, this is unfair. I was so, you know, we have this beautiful relationship. I was taking care of her. Why did she fire me? This is so unfair. My feeling, I was angry, upset, you know. Action, I carried the anger with me, you know, continue to think, why would she do this? Keep reasoning, why? And not being present 100% in the moment that I was doing, distracted, making errors, looking at the computer, but still thinking about this patient and why did she fire me? Not so pleasant with other patients, nurses, and colleagues. The result, unfair to myself and unfair to people around me. I had this one incident with the patient, but she fired me. That's okay. But I was having this ripple effects with the other things going on with my life. Now the intentional model, just because, you know, you could choose a different thought. So the circumstance remains the same. She's this 80-year-old female recovering from COPD with incidental finding of a dilated aorta. And she fires me and requests a new physician. That's hard. She is advocating for her own health. This is her right, her health. She can ask for a new physician. That's totally okay. My feeling, it's a closure. If the moment I shift the focus from me to her and she advocating for herself, she's doing the best for herself. So I'm not in the picture. It wasn't my care that she wasn't good. It wasn't my personality that she wasn't happy about. It was nothing related to me. She was just advocating for herself. The action, I show up 100%. As a good physician, I advocate for my patients, support the need of my patients, find a physician who can support this patient's needs, present in the moment, respect her decision and health needs. Result, be the best advocate for myself and the patient. And if we notice, going from the unintentional model to the intentional model was just a change in my thoughts. So I could have a grumpy day, but I choose to change my thought and then make it a better day. So again, reiterating the model here, because I think that is my takeaway point from the lecture. The CTFAR, the circumstance, thought, feeling, action, inaction, and result. So do we have time for the other part of my lecture, or are we short on time, Dr. Day?
I think you can go on.
Okay.
Yeah.
Okay. So once you have this awareness that your thoughts can change certain things, and you have 40,000 thoughts, how do you choose? How do you choose which thought is serving you? And sometimes these thoughts are sneaky. They come in, you know, like, I'm not good enough, or I'm average. Actually, that's a sneaky one. I'm average. And then you will think, oh, average is good. But average makes you think I'm not good enough. That's the sneakiness of being average. So once you have the awareness of these thoughts, you are sometimes lost. In mindfulness world, we call it the second arrow, because you are judging your judgment. So first you have this judgment, the sneaky thought that I'm not good enough, and then you're judging yourself. Oh, I am judging myself for judging myself. That's the second arrow. That's even worse, because you now are aware of your mind doing this. So, all of us are from India, and we have this rich culture of mindfulness practice, and we can always lie down and think about these mindfulness practice. And that's what got me through, because once I had understood that I had all of these thought processes going around in my mind, the judgment came in, and I was like, why am I judging myself for thinking all of these things? But I was not able to find the answer so well in the coaching world, what I could do in the mindfulness world. So that's the second part of my lecture is on mindfulness. So what is mindfulness? Like I said, all of us from India, we know and hear a lot about mindfulness, but mindfulness is a state achieved by focusing one's awareness on the present moment while calmly acknowledging and accepting one's feelings, thoughts, bodily sensation, and it is also used as a therapeutic technique. There are 4 foundations of mindfulness: the mindfulness of breath, the mindfulness of emotion, mindfulness of mind, and mindfulness of conduct, or the dharma. At this moment, I know we are short on time, but I would just like to invite everybody to do a very short 5 minutes or maybe lesser mindfulness practice with me. And let's see if we can get to our understanding our thought process a little bit more. So I'll ring a bell. I request everybody to sit comfortably after that, and then close their eyes if they want to. And then I would say some words and guide the meditation, and then we'll finish up with the bell as well. Sit comfortably. In an erect posture. Close your eyes or lower the gaze, whichever you feel comfortable. Taking some deep cleansing breath. Scanning your body from head to toe and looking for any stress points and intentionally going there and relaxing those points. Now noticing your breath where you can feel it the most, whether it's your nostril, your chest, your belly. Having the curiosity of feeling those feelings. And noticing the thoughts which come up. Maybe planning your day after this, maybe planning tomorrow. some emotions, bodily sensations like pain, tingling, numbness. And then getting your focus back on the breath. The mind will go back to the thoughts. And the moment you realize that the mind is away, that is the moment of mindfulness. This is the mindfulness of breath. Sometimes counting helps. 1 in breath, 1 out breath. The key points here are circumstances are all neutral. Our thoughts can lead to results, and mindfulness can make you aware of those thoughts. Some resources that I like to pass on. These are some podcasts which you could listen to if you're looking for some mindfulness stuff and coaching. Some apps. My favorite one is a 10% Happier app that I use a lot. Certain authors that have extensively written on these topics. My favorite being Brené Brown, Dr. Kristen Neff. She talks a lot about self-compassion. Pema Chodron and Thich Nhat Hanh. And some websites. This is the first website, is the website that I did the 8-week mindfulness course at the University of Massachusetts. These both are, the first one is the coaching website, and the next one is more of mindfulness stuff. Any questions? And these are my 3 kids, the reason why I started this mindfulness journey.
All right. So thank you very much, Dr. Gupta. I think it really calmed us all down, and this is kind of a new experience at the ACP Case File Symposium. So I think we also have with us Dr. Jyoti Bajpai. She's a ACP Council member. Dr. Jyoti, if you're there, you can come in with some of your thoughts on mindfulness, your questions for Dr. Shraddha Gupta.
Very good afternoon to, very good evening to all of you. Thank you, Dr. Amit De, for introducing me. And I have gone through all 2 lectures by Dr. Amit and Dr. Shraddha ma'am. So I am very happy and overwhelmed to listen Dr. Shraddha Gupta on the topic of mindfulness and practices in the physician's life. So it is a very good topic, and it is a very important to our life, because we are dealing day in day out these things to how to reduce our stress. So I think so the topics which covered by ma'am regarding the circumstances, thoughtfulness, and feelings, action, inaction, and results. So I think we have to go through the intentional process in despite of going through the unintentional process. So this is a very important thing. So just I want to know from ma'am, because for residents also, or in our physicians life also, how can we reduce our there is a fight day in day out with the process of ambition and happiness. So how can we put a balance in between these two in our ambition, because everybody wants to get achieve some good best in our lives, and how to become a happy. So these two things are very, very difficult and challenging for our lives. So this is my question to ma'am.
Very good question, Jyoti. I think happiness is different for everybody. For me, being a full-time practicing physician and practicing mindfulness and coaching is happiness. For you, happiness would be something else. For somebody who's not a physician, happiness is something else. So it's really important to actually find out what happiness means to you. Actually, most of the times we compare our happiness with other people, and comparison is the thief of joy. So if Jyoti has an iPhone and I want an iPhone, that's not what makes me happy. That makes Jyoti happy. So what makes me happy is probably not having a phone and just being in the woods, enjoying nature and doing my mindfulness practice. So, a lot of times I recommend journaling. I don't know if anybody here is aware of how to do that, but just sitting down for 5 minutes and writing down your thought work and see what comes up out of it. And slowly you will be able to get in touch with your self, and you will find out what makes you happy.
Yeah, thank you, ma'am. And I think one thing is more important. Everybody should have some mentor like you, and other members also, who would guide us in our journey. So thank you, ma'am.
Thanks.
Dr. Shraddha, I would just like to come in and thank you for your excellent talk. And let me tell you that I am also a practitioner of art of living practices. And the first thing they ask is that what will make you happy? So I think this is a very tough question to answer. And every time it will keep changing, and you will find that even if you get everything, you will not become happy.
Yeah.
So it is happiness is something which is so you have rightly pointed out, and the cases which you have highlighted, I think each one of us faces this kind of challenges almost every day in our routine practices, and something like that happened to us every time, because not every case is a success. Every time we feel that everything may not be going our way. So, but your model really gives us a structure to think about it, that it is something which can be addressed also. So it is not necessary to live with that kind of thought and keep on destroying your rest of the peace. So you can still be peaceful, and you can move away, and you can get positive inputs from every life situation. So as rightly pointed out by you, that every circumstance is neutral, because we see from our own perspective. So I think very well highlighted. Thank you once again for joining today.
Thank you so much for your kind words. This is a very big topic. I was really struggling to fit into 30 minutes of this, but I wish I had more time and we can go into a little more details. And I think the audience is amazing because everybody was able to follow through. But yeah.
We will certainly plan something more on it, and we can think of a kind of workshop also, maybe an online workshop on mindful physician.
Sure. Happy to come back always. ACP is home for me. So happy to come back and talk about mindfulness and coaching anytime.
Yes. Dr. Amit, Dr. Abhishek, your thoughts?
Abhishek, please come in with your thoughts.
Yeah. See, it's always mindfulness is something which you feel within yourself. But it's the moment of satisfaction where you feel, okay, I'm happy with this at this moment, or I would be happy in the next moment. That depends on yourself itself. That is more important. Other person can't tell you that you have a good mindfulness or you have a good uh, satisfactory origin within yourself. It's you who would actually decide when you are happy and when you are satisfied. That is most importantly. And once we actually stop competing with others, at that moment, I think we would actually be more satisfied and more happy. Competing in the sense, no, I'm not saying in the sense of academics, it's okay. It's very good to compete yourself in the academics. But once you start competing personally, then it becomes difficult for a person to be happy or be satisfied. That is more important.
And Dr. Amit Kinare, your cases were also very excellent. I'm traveling in car, so my video is off. I'm really sorry for that. But you really highlighted the importance of evaluating the chest pain in detail. And Dr. Anush Maheshwari sir just informed me that he has some other commitment to be here to conclude this session. But I would again thank Dr. Amit Kinare for the wonderful case presentation, Dr. Nida Gupta from Arizona for discussing the mindful physician, and as usual, Dr. Amit Dey for the wonderful moderation, Dr. Abhishek and Dr. Jyoti for planning this ACP India case file. So this was the last ACP case file of this year, and next month we will be back with some more thoughtful topics and more. And we wish you from the ACP India chapter a very, very happy New Year and thank you
Happy
from
New
my
Year.
side.
Bye-bye. Thank you.
Happy New Year. Bye.
Thank you very much. Happy New Year, everyone.
Thanks, Amit.
Thank you, Amit.
Thanks,
Thank you. Thank you.
Thank you.
Thank
Thank you, Dr. Abhishek.
Shraddha, Amit Kinare, Amit Dey, both. Thanks a lot.
Thank you.
Thank you, Dr. Abhishek.
Thanks, Jyoti. Thanks, Dr. Jyoti.
Thank
Thank
you.
you.
Happy
Thank
New
you,
Year,
everyone.
Dr. Jyoti, Dr. Abhishek. Happy New Year, everyone. Thank you.
Thank you, Dr.
Thank
Amit.
you very much.
Okay, good.